Bag valve mask. History. The bag valve mask concept was developed in 1956 by the German engineer Holger Hess and his partner, Danish anesthetist Henning Ruben, following their initial work on a suction pump. Hess's company was later renamed Embolism, which has manufactured and marketed the device since 1956. An ambu bag is a self-inflating bag resuscitator from Ambu/S, which still manufactures and markets self-inflating bag resuscitators. Today, there are several manufacturers of self-inflating bag resuscitators. Some, like the original ambu bag, are durable and intended for reuse after thorough cleaning. Others are inexpensive and intended for single-patient use. Initially produced in one size, BVM are now available in sizes for use with infants, children, or adults. Standard components. Mask. The BVM consists of a flexible air chamber, the bag, roughly a foot in length. When the face mask is properly applied and the bag is squeezed, the device forces air through into the patient's lungs. When the bag is released, it self-inflates from its other end, drawing in either ambient air or a low-pressure oxygen flow supplied by a regulated cylinder, while also allowing the patient's lungs to deflate to the ambient environment, not the bag past the bag and valve. Bag and valve combinations can also be attached to an alternative airway adjunct instead of to the mask. For example, it can be attached to an endotracheal tube or laryngeal mask airway. Small heat and moisture exchangers or humidifying/bacterial filters can be used. A bag valve mask can be used without being attached to an oxygen tank to provide room air 21% oxygen to the patient. However, manual resuscitator devices also can be connected to a separate bag reservoir, which can be filled with pure oxygen from a compressed oxygen source, thus increasing the amount of oxygen delivered to the patient to nearly 100%. Bag valve masks come in different sizes to fit infants, children, and adults. The face mask size may be independent of the bag size. For example, a single pediatric-sized bag might be used with different masks for multiple face sizes, or a pediatric mask might be used with an adult bag for patients with small faces. Most types of the device are disposable and therefore single-use, while others are designed to be cleaned and reused. Method of operation. Manual resuscitators cause the gas inside the inflatable bag portion to be force-fed to the patient via a one-way valve. When compressed by the rescuer, the gas is then ideally delivered through a mask and into the patient's trachea, bronchus, and into the lungs. In order to be effective, a bag valve mask must deliver between 500 and 600 milliliters of air to a normal male adult patient's lungs, but if supplemental oxygen is provided, 400 ml may still be adequate. Squeezing the bag once every 5 to 6 seconds for an adult or once every 3 seconds for an infant or child provides an adequate respiratory rate: 10-12 respirations per minute in an adult and 20 per minute in a child. Professional rescuers are taught to ensure that the mask portion of the BVM is properly sealed around the patient's face, that is, to ensure proper mask seal. Otherwise, pressure needed to force inflate the lungs is released to the environment. This is difficult when a single rescuer attempts to maintain a face mask seal with one hand while squeezing the bag with other. Therefore, common protocol uses 2 rescuers, one rescuer to hold the mask to the patient's face with both hands and focus entirely on maintaining a leak-proof mask seal, while the other rescuer squeezes the bag and focuses on breath or tidal volume and timing. An endotracheal tube ET can be inserted by an advanced practitioner and can substitute for the mask portion of the manual resuscitator. This provides more secure air passage between the resuscitator and the patient, since the ET tube is sealed with an inflatable cuff within the trachea or windpipe, so any regurgitation is less likely to enter the lungs, and so that forced inflation pressure can only go into the lungs and not inadvertently go to the stomach. See complications below. The ET tube also maintains an open and secure airway at all times, even during CPR compressions, as opposed to when a manual resuscitator is used with a mask when a face mask seal can be difficult to maintain during compressions. Bag valve masks used in combat. Airway obstruction is a leading cause of death in battlefield trauma. Airway management in combat is very different from its civilian equivalent. In combat, maxillofacial trauma is the primary cause of airway obstruction. The injury is frequently complicated by a struggling patient, distorted anatomy, and blood, and these injuries often have significant associated hemorrhage from accompanying vascular injuries. Military paramedics face extreme challenges, including darkness, hostile fire, resource limitations, prolonged evacuation times, unique casualty transportation issues, command and tactical decisions affecting health care, hostile environments, and provider experience levels. They often have to treat multiple casualties using only the equipment they are carrying on their backs. Therefore, space is of primary importance, and compact bag valve masks, such as a pocket BVM, have been created to save valuable space in the emergency kit. Complications. Under normal breathing, the lungs inflate under a slight vacuum when the chest wall muscles and diaphragm expand. This pulls the lungs open, causing air to enter the lungs to inflate under a gentle vacuum. However, when using a manual resuscitator, as with other methods of positive pressure ventilation, the lungs are force-inflated with pressurized air or oxygen. This inherently leads to risk of various complications, many of which depend on whether the manual resuscitator is being used with a face mask or ET tube. Complications are related to overinflating or overpressurizing the patient, which can cause 1. Air to inflate the stomach called gastric insufflation, 2. Lung injury from overstretching called volatrauma, or 3. Lung injury from overpressurization called barotrauma. Stomach inflation/lung aspiration. When a face mask is used in conjunction with a manual resuscitator, the intent is for the force-delivered air or oxygen to inflate the lungs. However, air entering the patient also has access to the stomach via the esophagus, which can inflate if the resuscitator is squeezed too hard, causing airflow that is too rapid for the lungs to absorb alone, or too much, causing excess air to divert to the stomach. Gastric inflation can lead to vomiting and subsequent aspiration of stomach contents into the lungs, which has been cited as a major hazard of bag valve mask ventilation, with one study suggesting this effect is difficult to avoid even for the most skilled and experienced users, stating when using a self-inflatable bag, even experienced anesthesiologists. The study goes on to state that stomach inflation is a complex problem that may cause regurgitation, gastric acid aspiration, and, possibly, death. When stomach inflation leads to vomiting of highly acidic stomach acids, delivery of subsequent breaths can force these caustic acids down into the lungs, where they cause life-threatening or fatal lung injuries, including Mendelssohn's syndrome, aspiration pneumonia, acute respiratory distress syndrome, and pulmonary injuries similar to that seen in victims of chlorine gas exposure. Another reported complication was a case of stomach rupture caused by stomach overinflation from a manual resuscitator. The causative factors and degree of risk of inadvertent stomach inflation have been examined, with one published study revealing that during prolonged resuscitation up to 75% of air delivered to the patient may inadvertently be delivered to the stomach instead of the lungs. Lung injury and air embolism. When an endotracheal tube ET is placed, one of the key advantages is that a direct air-tight passageway is provided from the output of the manual resuscitator to the lungs, thus eliminating the possibilities of inadvertent stomach inflation or lung injuries from gastric acid aspiration. However, this places the lungs at increased risk from separate lung injury patterns caused by accidental forced overinflation called volatrauma or barotrauma. Sponge-like lung tissue is delicate and overstretching can lead to adult respiratory distress syndrome, a condition that requires prolonged mechanical ventilator support in the ICU and is associated with poor survival, e.g. 50%, and significantly increased care costs of up to $30,000 per day. Lung volatrauma, which can be caused by careful delivery of large, slow breaths, can also lead to a popped or collapsed lung called a pneumothorax, with at least one published report describing a patient in whom a sudden tension pneumothorax developed during ventilation with a bagged valve device. Additionally, there is at least one report of manual resuscitator use where the lungs were accidentally overinflated to the point where the heart contained a large volume of air and the aorta and pulmonary arteries were filled with air, a condition called an air embolism, which is almost uniformly fatal. However, the case was of a 95-year-old woman, as the authors point out that this type of complication has previously only been reported in premature infants. Public health risk from manual resuscitator complications. Two factors appear to make the public particularly at risk from complications from manual resuscitators. One, their prevalence of use leading to high probability of exposure, and two, apparent inability for providers to protect patients from uncontrolled, inadvertent, forced overinflation. Prevalence of manual resuscitator use. Manual resuscitators are commonly used for temporary ventilation support, especially flow inflation versions that are used during anesthesia induction/recovery during routine surgery. Accordingly, most citizens are likely to be bagged at least once during their lifetime as they undergo procedures involving general anesthesia. Additionally, a significant number of newborns are ventilated with infant-sized manual resuscitators to help stimulate normal breathing, making manual resuscitators among the first therapeutic medical devices encountered upon birth. As previously stated, manual resuscitators are the first-line device recommended for emergency artificial ventilation of critical care patients, and are thus used not only throughout hospitals, but also in out-of-hospital care venues by firefighters, paramedics, and outpatient clinic personnel. Inability of professional providers to use manual resuscitators within established safety guidelines. Guideline non-compliance due to excessive rate versus excessive lung inflation. Additional components and features. Filters. A filter is sometimes placed between the mask and the bag before or after the valve to prevent contamination of the bag. Positive end-expiratory pressure. Some devices have PEEP valve connectors for better positive airway pressure maintenance. Medication delivery. A covered port may be incorporated into the valve assembly to allow inhalatory medicines to be injected into the airflow, which may be particularly effective in treating patients in respiratory arrest from severe asthma. Airway pressure port. A separate covered port may be included into the valve assembly to enable a pressure monitoring device to be attached, enabling rescuers to continuously monitor the amount of positive pressure being generated during forced lung inflation. Pressure relief valves. A pressure relief valve, often known as a pop-up valve, is typically included in pediatric versions and some adult versions, the purpose of which is to prevent accidental overpressurization of the lungs. A bypass clip is usually incorporated into this valve assembly in case medical needs call for inflation at a pressure beyond the normal cutoff of the pop-up valve. Device storage features. Some bags are designed to collapse for storage. A bag not designed to store collapsed may lose elasticity when stored compressed for long periods, reducing its effectiveness. The collapsible design has longitudinal scoring so that the bag collapses on the scoring pivot point, opposite to the direction of normal bag compression. Manual resuscitator alternatives. In a hospital, long-term mechanical ventilation is provided by using a more complex, automated ventilator. However, a frequent use of a manual resuscitator is to temporarily provide manual ventilation whenever troubleshooting of the mechanical ventilator is needed, if the ventilator circuit needs to be changed, or if there is a loss of electrical power or source of compressed air or oxygen. A rudimentary type of mechanical ventilator device that has the advantage of not needing electricity is a flow-restricted, oxygen-powered ventilation device FROP. These are similar to manual resuscitators in that oxygen is pushed through a mask to force inflate the patient's lungs, but unlike a manual resuscitator, where the pressure used to force inflate the patient's lungs comes from a person manually squeezing a bag, with the FROP the pressure needed to force inflate the lungs comes directly from a pressurized oxygen cylinder. These devices will stop functioning when the compressed oxygen tank becomes depleted. Types of manual resuscitators. Self-inflating bags. This type of manual resuscitator is the standard design most often used in both in-hospital and out-of-hospital settings. The material used for the bag portion of a self-inflating manual resuscitator has a memory. These devices can be used alone, thus delivering room air, or can be used in connection with an oxygen source to deliver nearly 100% oxygen. As a result of these features, this type of manual resuscitator is appropriate for in-hospital use and in out-of-hospital settings, e.g., ambulances. Flow inflating bags, also termed anesthesia bags. These are a specialized form of manual resuscitator with a bag portion that is flaccid and does not re-inflate on its own. This necessitates an external flow source of pressurized inflation gas for the bag to inflate. Once inflated, the provider can manually squeeze the bag, or, if the patient is breathing on his/her own, the patient can inhale directly through the bag. These types of manual resuscitators are used extensively during anesthesia induction and recovery, and are often attached to anesthesia consoles, so anesthesia gases can be used to ventilate the patient. They are primarily utilized by anesthesiologists administering general anesthesia, but also during some in-hospital emergencies, which may involve anesthesiologists or respiratory therapists. They are not typically used outside hospital settings. As per a recent Indian study, these flow inflation bags can also be used to provide CPAP in spontaneously breathing children. The study quotes that this mode of CPAP is cost-effective in limited resource settings,